Hello, thank you for listening to the data mining project for Morgan McNutt and Evan Corlew. In this project, we're going to determine the likelihood of hospitalization and death from COVID-19 for individuals aged 20 to 29. COVID-19 has affected all of our lives day to day, starting in March of last year and continuing into now. So we want to look at the available data and see what findings we can have in order to communicate best practices so individuals can stay healthy. This data will help individuals understand based on information that applies to them if they are at risk, so that that information can be communicated to them through healthcare facilities, physicians, and other institutions, and they can practice healthy behaviors as a result of having that knowledge. Part of that too is public safety communications, and these have been critical because so much information has been coming to us about COVID-19. It's critical to know what is accurate and to get that information out in a timely manner. Data mining allows this to occur, takes all of the data that's coming in, analyzes it, and helps us understand the virus, how it affects individuals, and how we can curb its spread. Data mining results can also benefit businesses. As far as the economy goes, as infection rates go down, as hospitalization rates go down, and death goes down, then the economy can improve. Investors can be more confident in the stability of the market and invest in businesses. And for businesses, it can also help them understand ways to safely conduct business and safely, have employees, keep employees safe throughout the day. Physicians also need this data that can derive from this data mining to target patients and understand who are most at risk that good attention needs to be given to. And then also as far as resources such as vaccines, PPE, and staffing, understanding what groups fall into these categories and these classifications that we'll be talking about to understand how to staff up and make sure there are enough individuals to care for those at risk. This data comes from the CDC website. The data was supplied from healthcare facilities all across the United States, so it does span the United States. And it is information from March 1st until October 31st for individuals 10 to 29. Now, there was much more data available, additional age ranges, and also information from March 1st through now. Because of the sheer size of the data that is available, we did decide to limit it to these dates and to this age range to get some findings. And like we'll talk about later, before this information is deployed, additional information would need to be downloaded from this CDC database. As we began to prepare the information, we started to think first, okay, we need two models to look at this. We need a model for hospitalizations to see what groups are most likely to be hospitalized. And then we need a model for deaths as well, since those are the two things we were looking at. So to begin, the Excel file was imported into SAS. And then the data was assigned as you see on the right. A couple things to note is that for this model, hospitalization was the target variable. So hospitalization, yes, no. And then there were 3 rejected variables. These variables had a very large instance of being blank and not having data values, and also it's information that was not significant to hospitalization or death, so those were rejected. And then for the data partition, 50% was training and 50% validation, and that partitioning is the same for death. It was set up in a very similar way, except the target variable for this model changed to death, yes or no. The rejected variables were consistent across both the hospitalization model and the death model. For the data modeling, you can see the screenshot there on the right. The data partitioning occurred, like we said a minute ago, with the 50-50 split. Data was imputed, used the sample nodes as well as variable selection and principal components in order to get the neural networks, the regressions, the optimal decision tree, all the different parts and pieces that we need to have a full analysis and to do that model comparison to see which one most accurately predicted hospitalization. Very similar with death. Again, it was a different model because it was a different target. But again, imputed that information after data partitioning, use sample, variable selection, principal components, regression, optimal decision tree, all of those models to go into model comparison. And there were 9 different models that went into the comparison for both hospitalization and also for death. So evaluating the findings that were output for hospitalizations, the optimal decision tree was the model that best predicted this information, and that's due to the misclassification rate, which was the lowest of all the models, and then also the average square error, which again was lowest of all the models. For that optimal decision tree, since it was the main indicator, we looked at the splits. So the first split for hospitalization was whether or not the individual died, and the second was whether or not they were admitted into the ICU. The third one that we found interesting was race and ethnicity was the third split for hospitalization. And that indicates that death, admission into the ICU, and race and ethnicity are the best predictions of hospitalization as it compares to, as you can see at the bottom, medical condition or sex. For death, again, the optimal decision tree had the lowest misclassification rate and lowest average squared error. So again, the optimal decision tree was the best model. And for its splits, hospitalization, yes, no, was first. The second split, just like in the hospitalization model, was admission into the ICU, yes or no. And then the third split was medical condition, yes or no. If you'll remember, in the hospitalization model, race and ethnicity was more of a predictor than as compared to sex and medical condition. But for death, medical condition was more indicative than race and ethnicity or sex. With this information, medical professionals can protect those most at risk, especially for the medical condition piece, and help sure that they understand and have the prevention practices in place for individuals of pre-existing conditions to avoid their deaths. Hospitalization, sure, but also their deaths, because based on this data, it is more likely they will die than be hospitalized as it compares to these items. Now, for race and ethnicity, there does need to be an additional study done in order to look at specifically with race and ethnicity, how does that break out amongst the races and ethnicities available. But it does mean protection of the vulnerable, faster vaccination access. It helps inform who are the individuals that most need vaccination to avoid death, and that's consistent with findings the CDC has come out with. And in addition, analysis does need to go beyond the 10 to 29 years range in order to look at a holistic population data set as far as hospitalization likelihood and death likelihood. For if the target of 10 to 29 years is to continue and to focus on that group, there does again need to be an additional study that's done because this data went through October 31st. As I mentioned, the UK variant was introduced into the United States somewhere around the beginning of December, and that variant may have changed the likelihood and the best predictor of hospitalization and death. And so there would need to be an additional study to make sure that the findings hold true. If they do hold true, it makes the analysis and the results from this project even more significant. And some of the risks are, like I mentioned, more recent data that should be used to make sure that any variants don't change this data. Also need to be careful about communicating this out if there are not enough resources for PPE or vaccine or whatever that may be, and making sure that that is available to protect the populations identified in this project, and not to just, announce the data and then not have the actions to actually back up and improve or save lives. Privacy concerns, of course, do need to be taken into consideration anytime medical data is involved. This information was from the CDC website. There was also an additional expanded version, but both of them have scrubbed any items that would violate HIPAA and identify a certain individual. But that is something that does need to have due diligence and to make sure that that is the case. Thank you very much for listening to our analysis of COVID-19 deaths and hospitalizations. If you have any questions, please let us know.